You have seen yesterday the different point of the technique for the cuff repair with a massive cuff there. It was very interesting because arthroscopy is very useful because you have a multi-access of the cuff. My disclosure. The question is, I use a double row repair, and the big question is, double row repair could be more efficient than a single row. In the lab, it's always better to use a double row because biomechanics is better. But during in the live, the difference is very poor. And two techniques is available for repair the cuff there as well. Arthroscopic portal, it's very important to know them a little bit. There is a lot of different portal you can see on this picture. The most important is a posterior portal because it's an automatic portal. You use the soft point to make the portal, and after that, all of the portal could be made from interior to exterior. With the needle, you can check where is the best way for your portal, and you select the portal like this. And Neviasier portal is very interesting for retracted cuff tear because you can pass the suture through the cuff by this portal very easily, and you have a good access to the upper part of the cuff. You see the different landmark for the soft point. Anterior portal could be very interesting too. Inferior portal, 5 o'clock portal is difficult to do because you have a big risk to damage the nerve, but sometimes for very inferior part of the subscap it could be very useful. There is a different type of cuff tear. The C shape is a more usual cuff tear, and it's very easy to repair from interior side of the joint. The anterior L shape cuff tear is you need to check the capacity to reduce the cuff in the right position with the grasper, and you can check what is the best position of anchor on of the suture. U-shape is sometimes difficult to repair, and you need to use side-to-side suture to repair it. It's a very important point is the release of the capsule, especially in the anterior part. You need to clean the coracoid process and to resect and to cut the glenohumeral ligament, because after that you can reduce the supraspinatus definitively more easily. And it's very important to mobilize and to make a release of the around the coracoid to mobilize the subscap as well. Here you can see with the radio frequency, you need to clean to the coracoid process, and it's a very difficult point because sometimes it's bleeding a lot, but you need stop the bleeding step by step, and after that you are onto the coracohumeral ligament and you can cut it, and after you mobilize definitively easier the upper part of the subscap and anterior part of the supraspinatus. For the biceps tenodesis, I love to do biceps tenodesis on the upper part of the groove inside the joint. I use for that, I check the anterior wall of the biceps groove. It's the best assessment of the intra-tendinous tear of the subscapularis. And after, I select the best way for the anterior anchor, just behind the biceps. And I prepare the hole for the anchor. I fix the anchor into the bone like this, and after I use the simple suture of the first anchor. It's a double load suture anchor, and I use the suture passer from the back, from the soft point, and I pass the first suture very close to the biceps groove, and after I use the middle part of the suture for the suture passer, and I make a loop in the medial part of the biceps to create a lasso loop for the biceps tenodesis. I pass the suture into the loop, the free stitch into the loop. And after, I pull the two sutures by the anterior portal. I create the anterior portal from inside to outside. I cut the biceps. The biceps is practically fixed in the same position as normally. I tie the biceps. And for the other part of the repair, you check the size of the repair when you are inside the joint. For the small on medial size of tear, I recommend to stay into the joint to prepare the positioning of the anchor, but after that you go out. You can go outside. You check the biceps groove here. It's the anterior portal. Okay. You can create a posterior hole for the posterior anchor. You stay inside the joint. I mean, it's good to pass the suture in the right position as well, like this. And after this, you retrieve the two sutures by the anterior portal, like this. And after, you can go into the subacromial space, and you can prepare the subacromial space as well. And you see from the lateral view, you move your scope by the lateral view, you can check the two layers of the infraspinatus. It's very important to repair the inferior layer, the deep layer, and after with the suture passer, you can pass the suture as well in this position posteriorly and two anteriorly after. You pass the two sutures here, you retrieve the two sutures by the back, and after you pass the two anterior sutures. I use the knotless technique with the tape. I mean, it's for the small tear is good, but for the big and massive cuff tear, I suture my tape to be okay with that. and to reduce the cuff in the right position like yesterday, you can see during the live surgery. And after that, I fix laterally, posteriorly in first, the two tapes, one from back, one from anterior part, and after anterior, the two tapes with anterior. The same with the anterior part. Sometimes it's bleeding a lot laterally because you have many vessels on the lateral part of the great tuberosity. And you can cut it, and you have the final aspect of the cuff here. It's good. If you have a dog hair, you can add another suture to be safe. Subscapularis repair is more difficult, but you need to clean more and to respect the lateral edge of the subscapularis, and I think it's very easy. For the transtendinous cuff repair, I prefer complete the tear to be safe and to repair very well. It's you see here the repair of the subscapularis. With the suture bridge technique, it could be very easy to do if you want good cleaning. You see, it's my series of cuff repair. There is a multiple combination to repair the cuff, and you need to use all portal as possible. Not less technique is easy for small tear. For massive cuff tear, I recommend to tie the suture before you fix laterally. Thank you so much.